Good morning, good afternoon, and good evening. My name is Helene Bengtsson. I am a physical therapist at Northwestern Medicine at this current moment. I am primarily a pelvic health PT. My journey into pelvic health PT actually started out with me being an ortho PT and then just finding that I really enjoyed this population that generally was overlooked in orthopedics. I would see hip patients, back patients, even your foot patient that could possibly have something that you thought was orthopedic, and then there was a missing link where somehow it related to the pelvic floor, and that's why I ended up going into it. So my background is orthopedics, but then I jumped into the pelvic health world. So my job is to introduce you guys to pelvic health and show you why pelvic health is actually important for you guys to know as orthopedic residents. So let me share my screen, and we will do this in a series of about 4 or 5 lectures so that y'all can have a over-compassing view of what is going on, okay? So the first one is really just thinking about how do we convince you guys to understand that pelvic health is really important. So I don't have any disclosures. Again, like I said, I work for Northwestern Medicine. I also own my own PT practice called ERA Physical Therapist and Therapy and Pilates. And then I also teach continuing education courses, as well as I am the president of the pelvic section at AONT. So general objectives for today and for the actual lab portion. But first off, just think about any patient where you potentially had suspected some form of pelvic floor issue, whether it be a hip patient, a back patient. Those are usually the most common ones. And so I want you to start thinking about these questions. Think about these patients that you've already seen. So people with chronic low back pain will often have pelvic floor dysfunction. True. Pelvic girdle pain is a common concern of female triathletes. Also true. There is no correlation between hip weakness and urinary incontinence. False. 1 in 2 women experiencing pelvic floor symptoms stop playing a sport or exercising. Unfortunately, that is true. So when we look at general statistics as to, let's go back again. Why won't it let me go back? There we go. So if we look at general statistics, right? 95.3% of female patients with low back pain have some form of pelvic floor dysfunction. So in all of your patients that you've ever seen, whether it be while you are in PT school, while you're in clinic right now, while you're in residency, how many of you guys actually thought about the pelvic floor when it came to these patients? Now, a lot of these statistics are going to basically be female or people with vulvas, and that's because that's where the majority of the research is so far. But this still accounts for those who are penis owners or male patients. Same thing, 43% of females have symptoms of urinary incontinence prior to total hip replacements, but then after the hip replacement, the symptoms actually persisted or worsened. So think about your hip weakness that comes with a total hip replacement. It doesn't matter which approach you're doing, whether it be posterior, lateral, anterior, there's still going to be some form of hip weakness that we get, and we do see an increase in incontinence. Now, as we keep going through this, there's a significant amount of correlation between urinary incontinence and low back pain. So how many times have you actually screened for any form of incontinence when it comes to your typical low back pain patient? Honestly, earlier in my career, I never would have. I never would have even considered these symptoms other than when we were screening for cauda equina. So hopefully we're starting to get you into thinking about why these things are correlated. So when we look into the CPGs that you guys have already studied, one thing that I want you to notice is, right, we're talking about range of motion, we're talking about morning stiffness when it comes to osteoarthritis, right? We look at the examination, think Faber, hip range of motion, hip strength, right? And we look at all the recommendations, typical ones that you would normally see in a CPG. Then we go into a non-arthritic hip. Again, you see Fadir, Faber, you see some more functional testing that you're supposed to be doing, all things that you probably should have already done in clinic, right? And the recommendation still stays the same. Range of motion, strengthening, patient education, neuromuscular re-education, everything that you're already going to be an expert in or probably already are. We look into the diagnosis of low back pain, right? This one's from the DoD, the VA, so a little bit different type of writing, but same thing that we're looking for is exercise, manual therapy, manipulation. Now we're starting to see them actually take into account neuroscience and pain education, all things that you're hopefully already learning about within your residency. Same thing for chronic low back pain, recommendation strengthening, trunk activation. You've seen these things over and over and over again. But where's the pelvic girdle? So when you think about general anatomy, all the paraspinals connect into the pelvis. Piriformis, it goes into the pelvis. We talk about piriformis syndrome. We talk about low back pain just as a general entity. But in all of these CPGs, where was the pelvis? Did it even exist? Not really. So if we go into the clinical practice guidelines of the pelvis, we look at something like pelvic girdle pain in the antepartum patient population. So these are patients that you will actually see. It's not just pelvic health PTs that should be seeing pregnancies, right? This is for any PT out there. So risks of getting pelvic girdle pain when it comes to pregnancies is a history of other pregnancies, higher BMIs, work dissatisfaction. You've seen these red flag or these yellow flags before. It goes into this population. Now, when we look at the exam measures and everything, notice how we've already seen the DRI before. We've already seen the ODI before. These are all orthopedic assessments. We're just translating them into a different population. So a lot of interventions for these people, and what I find to be fascinating is you as an orthopedic clinician, hopefully you're learning about HVLAs, the thrust manipulations, right? And so one of the things that we find within these CPGs is that we can actually do manipulations on somebody who is pregnant. Now, I personally would not do it on somebody in the first trimester because the chances of a miscarriage during that time is fairly high, of which it's not of any cause of the physical therapist who does a manipulation. However, you just don't want that type of liability on you. I also don't generally perform them in the third trimester, more so in that like 34 weeks and past that point, more so because of risk. You don't want to induce an early labor. The likelihood of that is also still low, but you don't want that liability. But in the second trimester, that's a golden area where you can do different forms of manipulations. And there is some good evidence for relief of any type of pain for these people. So that's, I think, pretty shocking. So in the postpartum population, we start looking at risk factors for pain, right? Anything that you really think on this list is probably fairly understandable. So if you've had multiples, if you had a C-section, any type of depression, right? We know the correlation between mental health and low back pain or the chronicity of low back pain. Any type of work factors, high BMI. But breastfeeding is actually one of them because of the changes in hormones that are continuous when somebody is breastfeeding. So as we notice these populations, as we notice these CPGs that are normally thought as just pelvic health professionals CPGs, you notice that all of the tests and measures that we're using have actually been visible on the hip cases and the lumbar and the chronic low back pain cases. So though these people may be pregnant, though these people may be considered a pelvic health patient, these are actually patients that an orthopedic PT can actually handle as well, because honestly, pelvic floor PTs, we have a wait list that is beyond long. So it's helpful for orthopedic PTs to have a little bit more knowledge on how do we treat these people, how do we assess them. So there is strong evidence for postpartum people that if there is a severe amount of pain, sometimes we can actually use an SIJ belt or a belt around the pelvis just to help with some of that stability. But we will talk about all of this more in depth later. So chronic pelvic pain, again, you see that there's a lot of different forms of PT that we can actually do as orthopedic PTs, right? So even though this one does suggest pelvic floor muscle physical therapy, there's a lot of stuff that you can do externally that can help with the general pain because of how the hip muscles connect into the pelvis, the back muscles connect into the pelvis, how everything works together. So hopefully, as we're demonstrating this, you're starting to see that there is an overlap between these patients that you might have already seen and these CPGs that I'm showing you. So diving into the boring stuff more so right now is when we look at orthopedics, when we look at the lumbopelvic girdle, we see a lot of different types of outcome measures that we can use. And pay attention to these because you might have one view of them, but hopefully this gives you a different view. So I want to dive straight into the ODI and the modified ODI. And the only difference between the original ODI and the modified one is the fact that the ODI actually screened for pelvic health, where they asked about your sex life. So asking this question actually can really give a huge key or a highlight into maybe there may be some form of pelvic floor dysfunction going on. What ended up happening with the modified one is they removed the sex question and the input employment. So employment is a great thing to ask about, especially when you're talking about yellow flags. If you have some form of workers' comp, there's a lot of reasons why we should ask about employment. But I actually encourage people to use the ODI, the original one, because of the sex life question, because it can give you a little bit of an insight into, does this patient maybe have a pelvic floor dysfunction that I may have to go into further questioning on my subjective to screen for? So other screening tools that we actually have out there is AOM. So as part of the Pelvic Health SIG, we created a decision tree. So you can hand this patient to, or you can hand this screener to a patient when they're walking in doing the rest of their screening work. And this is a nice way to just screen, hey, is there a pelvic floor issue? Should I be evaluating this a little bit further? So generally what we're looking at is any pain history, incontinence history, sexual history, bowel history. And if there is any form of check in a box anywhere, there is a probability that there is going to be a pelvic floor dysfunction that needs to be addressed as well, or at least screened for. So let's go into the anatomy. The pelvis is divided into 3 layers of different muscles, okay? So on the right side, you see a penis owner. On the left side, you see a vulva owner. And I use those terms just to be more for inclusive language. So when we look at the pelvis, there's about 3 different layers of muscles. So the first layer and the most superficial layer we generally think of as the sex layer. The second layer, which is a little bit deeper, is sphincteric in nature, which is going to take care of the bowel and bladder. And then the third one is the deepest part of the pelvic floor, which is responsible for endurance, and some would say stability, though that's an arguable term. So when we dive into the first one, we can see on the outside, we've got the ischiocavernosus muscle that actually is just medial to the pubic ramus. Then you got the bulbocavernosus going down, or the bulbospongiosus as it's called in people with penises. And then you got your superficial transverse perineum. My anecdote is I call these my Gandalf muscles Because if you've ever seen or read Lord of the Rings, Gandalf at one point in time says, "Thou shalt not pass." So these are the muscles that are going to prevent any form of penetration or envelopment in that of a vulva owner. They're also very integral for our sex life. And we'll go into a little bit more of how these muscles work into our sex life and why these muscles are sometimes important to screen for when we are talking to somebody with any form of orthopedic issue. So the second layer of muscles, and you can see it a little bit better here, you can see there's muscles down here that wrap around the urethra. You can also see that there's muscle like that could be around the urethra. And a different view of the anus, there's muscles that are circular around the anus. These are sphincteric muscles. So what they do is they basically seal to make sure you don't have any fecal or urinary matter leaking without your consent. On the other hand, a dysfunction can be some form of retention or constipation where the muscles are unable to actually open up to allow for appropriate defecation of any form. The third layer, as we dive into the pelvis and we're looking at a superior view into the pelvis, there's a few different muscles, but they all come together to create the levator ani. They're there to help with support. So some people think, well, I'm a penis owner, I don't need support. You do. And the reason why is because let's say you're going to reach to the top shelf of your kitchen and you're picking up a Pyrex dish. Pyrex dishes can actually be somewhat heavy and awkward to take out of the cabinet. What we find is that the pelvic floor is one of the first muscles to actually contract as a precursor muscle to any form of shoulder motion to go up and reach for that Pyrex dish. So it's in these muscles that we do find that there's a lot of endurance and stability. If you actually look at EMG studies, the pelvic floor will always have at least about 2 microvolts of electricity or like movement going through them at any given time because they're always holding to support or holding to seal to make sure we don't have bowel or bladder matter leaking. So all of these muscles are generally responsible for support. However, the puborectalis, which is this horseshoe-based muscle, is also very in large part responsible for your bowel function, which we will dive into later. But just know that there's 3 layers of muscles. So general pelvic floor facts. So the pelvic floor attaches from your pubic bone and goes back to your coccyx or your tailbone. So pubis and the coccyx, not really movable bones. So it's not like you can go and lean forward and stretch like you could your hamstring. Sometimes you need a little bit more manual therapy in this area. But the pelvic floor actually mimics that of the diaphragm. So you can see how the pelvic floor looks like a sling down here. The diaphragm above creates that same form of sling, and it works equal and opposite. The pelvic floor and the diaphragm work together like a sump pump system. So as the diaphragm inhales, it will actually descend down, and the pelvic floor will also reciprocally descend down. And as the diaphragm exhales out and goes up, same thing with the pelvic floor. So they work like a sump pump. They also work in conjunction with the transverse abdominis. So the transverse abdominis and the pelvic floor, they work together like Q and U. They're always together. Unless you're Iraq, then you only have the Q. But they always work together. So sometimes we can actually use the diaphragm or the transverse abdominis as intervention strategies to help out with pelvic floor, even if you're not a pelvic floor PT that can work internally. So we just went over this. So as we inhale, the pelvic floor relaxes and descends. So let's say you have a patient with low back pain and you suspect that they have an overactive pelvic floor. You might try to do a little bit of diaphragmatic breathing with them, teach them how to actually have that appropriate inhalation. So that means those lower ribs moving out and laterally, not belly breathing, it's the lower ribs moving out laterally. That's going to probably help them start to learn how to relax their pelvic floor. especially since not many people think about their pelvic floor or have really thought about feeling it before. So sometimes it can be hard to cue. So we use other muscles that work in conjunction with the pelvic floor to help us out. So the other thing, just a little clinical pearl, is we can use the diaphragm to help teach the pelvic floor how to relax or do it in coordination with contractions. So as you exhale, the pelvic floor should engage. So think about when you're doing a squat and you're asking somebody to exhale on the way back up when you're pushing up through the weight, pushing up through gravity. You're asking them to exhale, or a Valsalva sometimes, but you're asking them to exhale oftentimes, and that also will cause the pelvic floor to actually engage. So you are cueing the pelvic floor without you even knowing it. But remember, sometimes the diaphragm, it's hard for people to do a diaphragmatic breath. So there's other muscles out there that are accessory breathers. So we often think about sternocleidomastoid, we think about our scalenes where we have that apical chest breathing. But we can actually use our serratus muscles to help with breathing as well. So usually we think of like serratus anterior as an upward rotator of the scapula, but if your scapula is locked and loaded in place, the other place that the serratus anterior attaches to is the ribs, so they actually can help with inhalation. So it's a nice way to get people moving and coordinating their breath is through some of these other muscles that you might already be working on. So when we talk about pelvic health, we do have to be comfortable with using different words. So how many times have you ever said vagina or penis in an evaluation? I would highly encourage you to start practicing with each other on saying these words, asking, do you have any pain with intercourse? Is there any difficulty with ejaculation? Have you had difficulties with achieving orgasm? Are you having any difficulties with your erectile function? All of these can be really important. And oftentimes we don't think of an orgasm being related to our orthopedic health or our general health, but actually it very much is. So a little teaser is we have started to see that orgasm can be related to prediabetes. So in our penis, in our clitoris, we have about 10,000 nerves, which is amazing. And we normally think of diabetes as an endocrinological disorder, right? You go to an endocrinologist to get insulin for diabetes. However, diabetes ends up in a peripheral neuropathy. And sometimes what we find is now that the peripheral neuropathy doesn't necessarily start in our feet or our hands, but it actually starts in the genitalia where the nervous system is not as important. And so somebody having a diminishment or then a lack of ability to orgasm has started to show a precursor to prediabetes and thereby diabetes, usually type 2. So these questions can become really important. Same thing asking about menstruation, asking about somebody's period. If somebody has severe amounts of pain that's unrelenting, unchanging, like a few days before their period, into their period, they can't move or anything like that, sometimes I start suspecting other things like maybe some endometriosis, pelvic floor dysfunction, those types of things. So here is an exhaustive list of different types of pelvic floor dysfunctions that we can see. But what I want you to notice is that I've put them into a Venn diagram where you see there's underactive pelvic floors and then there's overactive pelvic floors. So in the literature, there's currently I guess not an agreement on what type of terminology to use. So in some articles that you'll read, you'll see increased tone. Some may say overactive. Some say underactive or hypotonicity, right? So I personally use overactive or underactive because usually tone implies that there's some kind of neurologic dysfunction or neurologic disorder. Overactive, underactive usually more implies the muscle itself. So when we're looking as an orthopedic PT that cannot do an internal assessment, rather whether it be vaginal or rectal, we're always putting our brain into the camp of, is this pelvic floor overactive? Is this pelvic floor underactive? This is a pretty comprehensive list where you can then say, okay, I hear this person is saying they have tailbone pain, coccydynia. Is that an overactive or underactive? Most likely it's an overactive. Or let's say somebody comes in and they're postpartum and they say, you know what? I've been having hip pain, but I also feel a lot of heaviness in my pelvis. Usually that's indicative of some kind of prolapse, which would be the cystocele, the rectocele, enterocele, right? That would probably be more of an underactive pelvic floor. However, there is this middle ground where there are some that are both overactive or underactive, and it just depends on the other symptoms around it. So let's say somebody has stress incontinence, so they leak with laughing, coughing, and sneezing, or climbing trees or exercising, right? And they also feel heaviness in their pelvis, or they feel like they have that diastasis recti, probably more on the underactive side. But let's say somebody has stress incontinence, but they're also having pain with orgasm. High likelihood is they have an overactive pelvic floor. So what I want you to get out of this, is it overactive? Is it underactive? Which one is it? So there's lots of different references, but that's the intro to all of this. The next lectures will be on bladder bowel, and then pregnancy, postpartum, and sexual health. And then we'll go into a little bit about prep for lab, or different lab techniques that you can use and practice on each other. I will see you in the next one.